Dear colleagues, it's a pleasure for me to share some ideas about integrated imagery scripting-based treatment of recent trauma. The only thing is that it feels like mission impossible to share some ideas in 15 minutes and with this virtual modality. It activates all my schemas, but I'll do my best. Okay, so I had a chance to work with the 9/11 survivors, as well as with firefighters and paramedics. And also, I had the chance to work with the survivors of Hurricane Andrew. However, this situation, COVID-19, this pandemic, feels like something totally different. These are unprecedented times where many of us are feeling anxious, insecure, incompetent, fearful, and even mistrust some of the information that we are getting from different sources. Many of us are having common reactions to this recent ongoing traumatic situation. These common reactions mean that they are normal and we need to depathologize them. We don't need to talk about patients or symptoms. And it's also important that when we work with the patient, we do some self-disclosure of our own feelings and our own common reactions. It's normal to feel irritated, to get on each other's nerves when we are having a long confinement. Here in Argentina, we are on day 53 of a mandated quarantine. So unfortunately, some people are going to develop what's called acute stress disorder, and especially healthcare workers who are being exposed to actual or threatened death and serious injury. Unfortunately, they are seeing patients in ICUs, in respirators, patients who are dying day after day. Some may have intrusion symptoms, so they have recurrent involuntary and intrusive memories. For instance, they may hear at night the crying of one relative who was notified that his or her beloved relative had died. They may see the faces of relatives, patients' relatives who scream at them and blame them for not having taken good care of their relative. Some people may be having negative mood. That means that they cannot feel any positive emotions. All this is highly correlated with the early maladaptive schemas, modes, and coping modes. Some people may be having dissociative symptoms such as selective amnesia. Maybe a person may not remember who told her about the death of a relative. Avoidance symptoms are also common. Some MDs, for instance, they avoid feeling insecure and vulnerable, and instead they may show up as cold and insensitive. Some people may avoid external reminders, like I can think of some New York City patients who are not currently in New York, and they already told me that they want to avoid going to Central Park, as they associate Central Park with those trucks that contain dead bodies. Arousal symptoms are very common. Unfortunately, some doctors are making mistakes. And of course, we have frequent comorbidities, such as substance abuse, clinical depression. In my experience, it's very effective to integrate schema therapy with behavioral activation. Risk factors include a history of childhood adversity. Of course, we can think here of early maladaptive schema, especially from domain 1, disconnection and rejection. Interpersonal trauma, even if this is a naturalistic stress or naturalistic trauma, potential trauma, some people may associate this trauma with an interpersonal factor. Some people may even think that COVID-19 is a virus that was planted in Wuhan by a certain group. In effective coping strategies, we can think about the avoidant coping style. This is a major risk factor, and we can think of maladaptive coping modes such as self-soother coping mode, detached protector, avoidant protector, self-stimulating protector as well. Protective factors, of course, these are the good news. They are associated with what we call a healthy adult mode. And then I would like to briefly mention that there are 4 common trajectories of post-traumatic stress following trauma. There's a group, hopefully that's us, that's going to be resilient. Then there's a group that's not likely to have symptoms now, but are likely to have symptoms at a later point. A group that has symptoms right now, but it's likely to have a decrease of the symptoms in the near future. And then there's a group that has chronic post-traumatic stress symptomatology. I think it's important to use screening tools like the Acute Stress Disorder Scale, created by Dr. Richard Bryant. And now let's go to the research studies. There are few research studies about effective treatments, and unfortunately, the studies have methodological limitations. Now, there's a controversy in the field of acute stress disorder. Some experts think that we should know nothing, we should not offer clinical interventions. However, some of us think that we have to offer, that's a good idea to offer a clinical intervention with the population that is at clinical risk of developing PTSD. So I include myself among these clinicians. So we have interesting studies by Foa, by Bryant, by Rothbaum, by Shalev, by Herrero, and Artigas. And of course, I would like to emphasize that I believe we should be doing an integrated intervention based on imagery script. These are some recent studies about the impact of the quarantine on healthcare professionals. And let's go now to a brief schema therapy conceptualization. I believe that some people are likely to have their vulnerable child mode activated. Let's think about an MD who's likely to feel frightened, insecure, anxious, incompetent. If he has a demanding voice, that voice would say something like, you should know everything about COVID-19. If he has a critical voice, that voice would say, you're stupid, you did not know how to intubate patients and you had your course, your class last week. The punitive voice would say something like, well, you made a mistake, so therefore you deserve to be expelled from the hospital. And the guilt-instigated voice would say something like, you got infected and you're in quarantine, and now your co-workers, you know, your fellow doctors are likely to be overwhelmed, feel overwhelmed because you're not there. So of course we have the maladaptive coping modes, and the clinical presentation will depend on the presence of these modes. So if let's say that the doctor has an avoidant coping style, he's likely to go home, for instance, and get drunk. If he has a compliance surrender, he's likely to feel terrified or feel and act submissive with co-workers and even patients. If he has an overcompensation as a coping style, he's likely to act in a grandiose way and even become a bully to his patients and his co-workers. So what's the clinical goal? To activate and strengthen the MD's healthy adult mode and have this healthy adult mode listen to the vulnerable child mode's needs and be strong, reassure the little child, encourage the little child, understand, listen, protect, and comfort and validate his feelings. So now, I believe that we should update our conceptualization of the healthy adult mode, because some of what we used to call maladaptive coping modes may become in part adaptive coping modes, such as, for instance, a paranoid overcontroller may be effective as of right now and helpful to the healthy adult mode, because it's important sometimes not to trust some sources of information. So the recommended treatment should prioritize safety, physical and emotional stabilities. All researchers who are specialized in trauma would agree with this. Do psychological first aid, use clinical assessment tools, and teach them affect regulation techniques. My favorite one is John and Ida's bubble technique integrated to a self-hug technique. And for patients who are going through confinement, such as in Argentina, and feeling suffocated, the Escape to Paradise technique is a little technique and very simple that I created and seems to be effective. Audio flashcards and video flashcards also help a lot. And now let's talk about what therapists should not do. I think we have to learn from the Mitchell model and avoid asking the person to fully narrate the trauma and explore all feelings and physical sensations, as this could potentially re-traumatize the person. Strengthen prior effective coping skills and help the person create new ones. If necessary, do not use schema therapies or report questionnaires, as this may be overly activating. Create a brief preliminary schema therapy conceptualizations and identify core emotional needs, as this will be our clinical map to develop our imagery rescripting. And finally, let's talk about emotional processing of the recent ongoing trauma. We'll use imagery rescripting, we'll do a quick activation of the traumatic event and imagine a better outcome, and use movement body analogs, as this could be a good augmentation strategy. Of course, this has to be researched in the future. Example, brief example, a female doctor who is feeling depressed because she longs being with her baby again. She decided to isolate due to the fear of infecting her. And in imagery, she creates a beautiful image where she's hugging her baby. And this image brings her joy, hope, and makes her feel uplifted. She feels much more relaxed. And I believe these are good clinical indicators that indicate that the imagery rescripting as an intervention has worked. Thank you very much, and I hope that some of these ideas are helpful to you.